Very good. Okay, we'll give it a few more minutes because although this is a pretty impressive group right here, we'll give a few more minutes for others to join.
Well, I will say that I really appreciated the discussion and the questions and everything that did come out of that last meeting. And I'm glad that people had some good takeaways.
Absolutely. And I'm just so glad I have the transcript because I can read it over and over and over again. Because it's, there's just so much to learn from, what you said and what really is the situation.
Yeah.
Hi, Eileen.
Hi, everyone.
Hello.
Eileen, can you and I meet separately just to go over some of the so we can start a process of how we're going to work this nursing center of excellence whole thing?
Yes.
Okay. Hi, Elle.
Hello. Good afternoon, everyone.
Good afternoon.
And Tony Ann, before we get started, can I also ask a question, or perhaps maybe you and I need to meet? Because as I mentioned on a previous meeting or call, we are in the throes of looking at our hospice regs.
Yes.
And while I do not want to imply that they're going to be done next week or the week after, we are moving along. And I don't want to lose this window where we could make some recommendations to our regulation review team, which I'm on the team. But we have a window here, and I want to take advantage of that window.
Yeah, and it probably would be perfect timing. So yeah, if we could, and maybe if we even, I know we have an agenda here, but we put the agenda together and then I read the transcripts from the advisory meeting, and I just have so many ideas in my head right now of, things we really should be considering and thinking about, and the regulations are probably a good thing to, talk about. I don't know if there are any regulations that we would have to consider, like for pediatric, like when I think about regulations as opposed to bill addendums or, things like that. But I'm just going to go ahead and get started because we're already at 1:05. So along that line, I was just, for those of you who didn't hear, I may have said it before you came on, I was able to really read the transcript for Jessica's presentation to the advisory committee last week. And I will say, and I'm going to pump up Jessica's head here again, because it's like, it has changed the way I think about pediatric hospice. After speaking to her and understanding how she is doing it where she is, it came to me last night, do we have what we need and we're just not using it? So when we have barriers, and we think about barriers, right? So we know staffing is a barrier. Okay, so we want to work on how do we get nurses to rotate through hospice, pediatric hospice, and kind of try and grow the pool of nurses, APRNs, social workers, which, that's a little bit easier. We know that's a barrier. But when we say we have a barrier to providers and, families themselves, because they don't really understand the benefits of hospice, and no one wants to give up, right? No one wants to give up their private nurses that, and like the more I listen to Jessica, I'm like, wait a minute, guys, what are we doing wrong here? We as providers, number one, and I was going back and forth with, what Dr. Moss was saying, and then, what Jessica was saying, and we need to understand better, and we're doing it now at regional, thanks to Jessica's meeting with us personally here, where we're saying, okay, this is a concurrent care item and should continue to be billed as concurrent care. This is a hospice item, and this is something that we would cover. But then also, and Jessica, keep me honest here. If I'm a provider and I'm saying to myself, well, I don't, I can't, the trajectory of an illness, or to say that someone is terminally ill and is going to, die in 6 months. But we have to think of it through a different lens. That's if there was no interventions being done. That was if we don't have concurrent care where these children can have curative interventions along the way. As a provider, I would say, well, if we took all of that away, this child will probably die in 6 months. And that's what you're certifying them to. So while we're trying to break down these barriers of how do we get people to understand, that it's not giving up, that yes, they have to sign on to hospice, but it's a totally different way that we would have to present it, and still be able to, and I see Regina's on, and maybe this is something that, Regina and Jasmine could help us with. Are we really seeing that things that belong under concurrent care and to be continued to be paid for under concurrent care not being paid for? Like, I think we've thrown a problem out there that we don't really even know if it exists. So any thoughts on that? Because I've like turned the cart a whole other way, and I don't know if, I'm being crazy, or I don't know. So what are your thoughts? And Barb, I'm going to ask you first.
So I think that's a question we may want Tracy to help support with. Are there, and again, I'm not a billing expert, so that's why I love Regina and Jasmine, and we love to
Right.
say DPH, we're not the financial people.
Right.
But are there CPT codes or diagnostic codes that are not being paid for that are related to concurrent care, and identifying, is it, to your point, we need to identify the problem to act on the problem. But if it's not, if this is just anecdotal information, we need to hear from the payers.
Exactly. And there's an article, Jess, I did get this from you, right? The state of pediatrics. Can you, I don't know if we sent that to everybody, but can you, I can scan it in myself or just send it from you, but it might be at your fingertips. If you could send that eventually to everybody to understand. The article is the state of pediatric concurrent hospice care in the United States. And the article is really saying, we don't understand concurrent care in this country, and we're not using the benefits of concurrent care when it comes to pediatric hospice. So I think a really good education on, concurrent care might help us, because we're not, from what I'm reading and from what I'm hearing, just because someone signs on to hospice, we don't have to say, well, this child will die in 6 months. It's if we took away all the interventions, if we took away all the curative things that we're doing for this child, that's how you have to look at it, and then say, yes, I certify them. We have babies on for a year, 2 years, because they can have all these curative things. And I think it's a big push of education. I think it's a big, I think concurrent care has probably been an answer to some of the things we've been calling barriers, and we just don't know how to use it. So, Jessica, Melissa?
Yeah, is this an issue of the fact that most of the time we bundle pediatrics with adults, and so that therefore with adults, there's more or less an assumption of the outcome, whereas with pediatrics, we should segment them differently to address a lot of the curative or the concurrent care measures that might prevent or delay death.
Yeah, Jess, how do you feel about that?
Yeah, I think that's such a common occurrence that really happens across multiple states. It's certainly not unique to Connecticut in any way, but I think there is this inherent grouping that does happen with the adult side because it's typically the adult practitioners that are providing support for pediatric patients, at least initially when programs are being built and taken off. And everybody in the infrastructure of a hospice is coming from an adult lens, right? We have compliance officers that have been in adult-based compliance. We have CEOs that have been in adult hospice. And so I think it's very natural and very normal to have that lens going into it. And it's not to say that there aren't similarities in pediatrics because we are still being good stewards of the hospice regulation. We do still want to make sure that what we are doing is in compliance with eligibility standards and things of that nature. But there is a different lens under concurrent care. And all that is just opening the door of access and thinking about every pediatric patient as being an open access patient. But at some point, to be boundaries and barriers put in place. Otherwise, we could consider thousands and thousands of children that could potentially be eligible for this support. But it really is, I think, even just speaking back to the point about the payers and understanding directly from the payers what their perspective is, understanding where they also draw the line, because there might be mutual benefit in having kids enrolled in a concurrent hospice care program. But certainly we don't want to open the door for every single person. And then I think that speaks to that palliative program need that I know has been brought up as well, and just delineating those services.
Right, absolutely. And I completely agree with that. I kept, like, last night, I'm just coming from the lens of all the barriers that we've been talking about for the last year. Well, they'll lose this, or well, they can't have that, or well, the physician doesn't want to certify them terminally ill, or, blah, blah, blah. And we have concurrent care. I mean, that's, it is.
Tony, and do providers understand, the real boots on the ground providers, do they have as good an understanding of, so Eileen, thank you. We need to start there with them.
You know what?
Because if they don't know it, they won't order it.
I have to say, I have one provider who refers to us that gets it. One. That'll call and say, okay, this kid is blah, 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 but because of concurrent care, I'll certify, and one.
And what's your universe, Tony Ann?
The number of, like, providers I deal with, probably about 15.
So
probably about
that's
15.
a really low margin.
and forget, I'm 15 specialists, like a pediatric oncologist. I'm not talking about the regular, pediatrician out there that all of a sudden gets, hit with something with a kid, and they're like, oh God, this is, forget about that. So the idea is, how do we educate, right? How do we educate the providers and the general community? We had a press conference here, I think it was last week, with Senator Kushner, because Senator Kushner pushed for us to get money to expand our pediatric program. and it was successful. We, you know, we're in the budget. We got a grant to expand pediatric hospice at Regional Hospice. And one of the reporters that was here was from Hearst Media. And she said, you know, what is the biggest thing you hope that comes out of like this press conference and the exposure that you're getting about pediatric hospice? And I said, the biggest thing I hope for right now is that pediatric hospice comes out of the closet, because we just we don't get it. And I've been so ready to point my fingers at, okay, it's you know, it's Medicaid. No, it's not Medicaid. It's this. No, it's, you know, it's so hard. I feel like they kind of have given us a path and we just don't understand it. So go ahead, Eileen.
Tony, and remember and Barbara, you will as well, there was a national survey put out by NHPCO last summer. Jess, you know.
Yep.
I asked for that data for Connecticut, and it's incomplete, but one of the things that did spill out was concurrent care is confusing and that there's not a good understanding amongst our providers.
Right.
Specifically, because I filed that to say, that could be a future educational point, and how would that get disseminated? And, you know, you could be a whole campaign around that, how to access and so on.
And
So I
that,
can get that data to share with everyone. It came out of, it was just made public just last month, maybe?
yeah. Yeah. And
Wow.
when they
Okay.
published the last survey, I think 2020 was when the first survey came out. Very similar feedback. And I think that's a big goal of all of the different agencies that are operating on a national platform, is to try to increase that awareness. But it really does come down to the community connection and being able to foster those relationships and provide the education from those sources that are actually meeting and seeing these kids and these families, to help have those conversations. But speaking to your point, if they also don't know what's available and what's out there in a time when things are also very uncertain from a healthcare perspective, that it's going to promote ongoing uncertainty. And so it really is that detailed, person-centered approach, really, for a lack of a better word, being able to really individually identify those potential referral areas and have those conversations.
Yeah, and you know, it's funny because I think part of the confusion, and you know, we get this a lot, and we've started to now push back on a little bit. Like, we'll get a referral and they'll say, well, you know, we want to keep it on the back burner right now because they're really not ready for hospice, and I don't know if they ever will be, because then they're going to lose their private care nursing. And now I go, wait, are you sure that, like, are they really going to lose their private care nursing? I mean, and you know, and now, you know how many we've said over the past year, oh, okay, yeah, we get it. They're going to lose their price, so we won't put them on, you know. And it's like the whole different world. And I think the couple of providers we've had that have said to me, oh, you know, yeah, they can't have both. They can't be on hospice and have private nursing. And I'm like, oh, okay. And it's like, no, wait, wait, look at Jessica's face. Is like, no, yes, they can. So the idea, I think we need to make like a couple of pillars, Melissa, you know, like you were thinking about what are the goals that we can get to. And I think one thing is how do we, or what kind of proposal or recommendation do we make that is an educational thing towards all providers about concurrent care? Like, what would that look like, and how do we do it, and how do we do it with the help of, you know, like the state? And so one thing would be about that, educating about concurrent care, which is huge. We already know one of the pillars is getting more providers, nursing and things like that. So that's already a pillar. And what I'd like to talk about with Barb, because you brought up a good point, is what do we do about regulations? And your hand is up, so why don't you shoot for that, Barb?
So can I do my first thought first?
Yes.
So we know, I think, and someone correct me if I'm wrong, but there's an assumption that many of these children are Husky beneficiaries.
Right.
And I can only speak from my experience, but we have had wonderful partnerships with DSS, working on enhancing information education for Medicaid beneficiaries. So, and this may be something Regina may have to take back, but is there work that we can do with Husky providers, not only on your first and your second pillar? How do we educate them? And Regina, I don't know if there's already, I just know DSS does lots of education through their rate letters, all kinds of vehicles that they have. So is there an opportunity there for both education and maybe enhancing the workforce? And I know providers would say the Medicaid, the Husky benefit is not that great. But in many cases, that they will continue to do the work because providers see the value and the necessity of the work. So there's an opportunity maybe there. But now the regulation piece, our window for hospice is open, and we are still brainstorming here about how do we incorporate pediatric hospice into our hospice regs. Currently, and you will know this, Tony Ann, that we have one license, and it's a home health care agency license. And then there's a service classification of hospice. So not all home health care agencies are hospice providers. We have upwards of 25 of them. But we want to, our hope is that we will separate the home health care, that will be one license, and then we'll have a hospice license. So two separate regulations to keep things clearer and cleaner.
Right.
And in those hospice regulations, we've started the conversation. And Elle, thank you for your report, because I did read it. I saw some of the challenges and recommendations, and I have brought them to the group for consideration. So that was the first step that I took. And what can we do in our hospice regulations that customize pediatric hospice? Because I, as a nurse for 40 years, I will say this, and I've said it in our palliative care report, Tony, and that Karen and I are working on, that kids are not adults, and they're two separate medicines. So we want to be clear about that in hospice as well. They won't be as expansive, but we want to give some note and mention and carve out to pediatric hospice because it is special. Not because we want it to be special, it is special.
Right.
So that's what I would say to that. And would open to any thoughts that others have. If we need to have a smaller work group, the whole theme of the hospice regulations, I want to be fair and reasonable, will not be pediatric hospice, but we will have mention where I'm making this up because I'm not a pediatric hospice nurse. Pain management, there may be different consideration, or no, I think a good example is families. The approach to families is very different because you have children, peers, siblings. It is just very different. The concept of family is a little bit different than with an adult who is in receiving hospice care. So any thoughts that people have about that, I would love to hear it. And not that it's TikTok, the end of the month, these have a bow and they're going to the commissioner's office. But as all of you can appreciate, developing regulations, it's a labor intensive process. And it has to be, we want it to be thoughtful and address high level needs. And I see this as a high level need.
Absolutely. Absolutely. So I see two hands up. Regina, you want to go?
Yes, sure. So, unfortunately, as the questions were coming up, I was still trying to log in and my um, laptop was coming in and out. I did hear a little bits and pieces about concurrent care and Husky providers. Unfortunately, I don't have the answer because it doesn't come from my unit. However, I can pass it along and get response. But Tonia, if you would so kindly as to email me the question that you want, answered directly around that, I will push it along and then, respond and send it back to the group.
Absolutely. Absolutely. Thank you so
Thank
much
you.
for that.
Yeah.
Okay, Jess.
Sorry, the unmute button wasn't working. I think really I think there's just such a rabbit hole that can be gone down in regulation, as there often is with pediatrics. But even just speaking to your point about families, there's a lot to be said about having the standards really be raised for children to meet where the adults are at. But I do think there are those very specific instances, even thinking about families and the fact that many of these kids go to school still, right? They could be in school, they could be going to all their follow-up appointments. Following that regulation of a nursing visit once every 15 days is difficult. For a pediatric nurse to potentially be able to do, because there is so many different things that they're operating on, because the hospice care team is not the primary medical care team at that point. But I think even with communication, I think there are so many different aspects where there could be more well-defined areas. But again, it would be quite a rabbit hole to go down. I like your idea of having a separate work group to really dive into those different things. But I think it's incredible thinking and just that acknowledgement of how different pediatrics is. And I just really wanted to also say my own appreciation for that.
Yeah, I completely agree. And I think it would be good if we could. And, like you say, Barb, we know it's not going to be all about pediatrics, but even just to get some things on the table that could be really a game changer. I think, it would be great for us to be able to do that. So maybe we can throw something together separately and work on that. However, I also think it's part of the work we're doing here, but to be able to just focus on that, I think if we can meet separately, that would be great.
We know of, and I won't belabor the regulation piece, but do we know of any states that do address pediatric hospice? And because we do a state to state review, and here's where I would say we shamelessly borrow sometimes the concept. If it's nice and we like it, we will drop it into our regs. So if there's any states that you think that we should be looking at, we will absolutely do that.
Yeah, I think there probably are several states that have some of those things outlined, and it would be worth looking into. And I can also just speak to individual experience of setting up those MOUs with specific Medicaid programs and having that memorandum of understanding of where the scope is. And so it could be a combination of both of those things, where there might be something that's built within the state regulation, but also something that could be more individualized, at least from my experience.
Right. Great. Eileen, and then I see Elle has her hand up also.
Elle, you haven't gotten an opportunity to speak yet, so if you want to go first.
So please go ahead.
And this is circling back to the definition and the need for education on concurrent care. For a point of clarification for my own learning, are we saying that with hospice and concurrent care, that this would be an opportunity to level resources for families, such as nursing and additional funding? So how would concurrent care and the Katie Beckett waiver blend together. So I know this is a problem in our state, the Katie Beckett waiver. We have, I think it's 320, Regina, I think sent this information earlier, 325 children receiving it and that many on the wait list. I've heard from parents is that the wait list is anywhere from 4 to 6 years.
Mhm.
And that some of our kids are not able to receive the benefit because they die before they are able to access.
You know, and that's a good point, and I don't know how to answer that, and maybe
So-
Jessica will, or maybe Regina, because I
Yeah.
really don't understand Katie Beckett. I don't, you know, when I think about pediatric hospice concurrent care, okay, so what is Katie Beckett giving us? You know, I know it's something, I just don't know what. So I don't know if anybody can speak to the Katie Beckett waiver and and educate us more on that.
Yeah, so that is one one question I have written down that I will get some more answers on that. Because I know the Katie Beckett waiver is, providing care for pediatrics in the community, you know, and from what I sent previously, it's pretty much it translates care from the facilities into the community. And as far as to what type of services, whether it's for concurrent care or not, I don't think the initial response that I sent really delve into that. So this is one question that I have, that I will research further on and bring it to the group as to how does the concurrent care and the Katie Beckett waiver work together, basically.
Thank you, Regina. And I
Yeah.
see Elle is shaking her head up there like she's chomping at the bit. So go for it.
Well, no, I just hopefully I can finally be a little bit useful. So I see not a lot, but in some of my work with Yale's medical legal partnerships, so we provide legal services to patients of Yale New Haven Hospital and their families. So I, in that capacity, only work with adults, but every once in a while we get an adult who has a minor child with special healthcare needs. And so I've seen some children who are on the wait list for Katie Beckett. And that actually it delves into a question my colleagues and I have been working on and really trying to think through, which I think we've talked a little bit about, different folks have talked a little about today, which is just what is the scope when we're talking about concurrent care, what exactly is the patient population we're talking about? So I think if we think about there are certain children who technically have a life-limiting illness. I mean, if you think about a child with type 1 diabetes, if they do not receive insulin, they unfortunately will pass away quite quickly. But once they receive insulin, then they're okay. And then we're really no longer talking about a child who is at risk of passing away. And so that doesn't really, I think what Jess was saying, that doesn't really seem like a child who would be a good candidate for concurrent care. And so then where do we draw that line? And then also a supplement question to that, which I think gets into the Katie Beckett issue, is if you have children who need more intensive care than say a child who has type 1 diabetes that's well controlled with regular insulin, there's no issues there. If we have children who would be candidates for institutional care, but they can be treated at home, but then they're okay. We're not really thinking about them passing away soon as long as they get those interventions. Is that a kind of child that we'd expect to see served by more of a palliative service that was directly integrated into their primary care? So those are the kind of questions that we're wrestling with. And I think I can, just from the silly lawyer reg perspective, is that it can be really helpful to just have a very distinct definition of patient populations for these regs, even if it's distinct, but even if there's a little bit of overlap, we're just saying like, maybe there will be some folks that match up in both, but something also to consider, especially if there's any sort of, there are some children, Katie Beckett, who may need to transition to hospice or concurrent care. So just trying to figure out where that web is. And then I think that would be, we have some thoughts, but we're not obviously on the ground clinicians. So just wanted to throw that out there, just distinct patient populations for Katie Beckett versus concurrent care, hospice versus some sort of like palliative pain management, where we're not really talking about a child with a life-limiting illness, that they're just getting that discrete intervention.
Jessica.
I I love that you brought up that point because it's definitely I'm not going to say a point of contention, but it's certainly something that comes up frequently when you think about appropriateness for hospice and you think about concurrent care. And this really goes back to the analogy I drew in that conversation about it's like we were given all of these doors to access things, but there was no like door handle attached. And so I think we really go back to the core of what hospice is, and that is really navigating and providing dignity and comfort at end of life. And the recognition with children is really just that we want to be able to offer that because whatever illness they're going through, there is that heightened potential for death. When we think about the example used with diabetes, that is and I'm not going to say easily managed because I definitely don't want to diminish how absolutely intensive that is on your daily life. But we have a good roadmap for how to manage diabetes. We have fairly, again, saying this sensitively, fairly accessible ways to manage this. And while managed, that child can lead pretty much a typically normal life, right? What we see on the other side of that of potentially a genetic illness, of which there really is no cure. It really is only management of symptoms. We might have evidence that indicates what that prognosis might look like, which gives us a little bit more credibility to offering that hospice eligibility. Because if it's a 2-year prognosis for trying to think of an example, Tay-Sachs, let's say, is an 8-year prognosis and they are 7, that's a pretty good indication. And if they're having other symptoms, that maybe there could be something that happens in the next 6 months. When we're looking at the current state of the illness, if somebody is having difficulty managing their diabetes, for example, let's say that their insulin is no longer effective, they're looking at having to change doses, they've been in the hospital 8 times. That makes us start to question, is this illness now progressing towards a potential friend of life? And all of that, to sum up, really comes down to the medical provider making that justification and that eligibility. And that really falls on the medical director, the physician, the referring physician. That falls back on them and their license, their understanding of the disease trajectory. But I think that's what makes it so hard from a regulatory perspective, is because every child is going to be so different. There's a reason why ACA didn't put anything in there specific about eligibility for concurrent care, because there is no one size fits all with a lot of these families. And I think it really comes down to the understanding on both the part of the managing hospice and of that payer source to delineate where that line is between something like a palliative following versus that hospice. And I think the other side of this too is it's important to have the Katie Beckett waivers and to have the palliative model of care accessible, because it allows there to be a stair-step method into a hospice plan of care. It's accessible from an emotional standpoint for most families. Typically, it'll provide more access to be able to give a better picture. So it gives us a better observance as medical providers to be able to be in the home. The issue with palliative care programs is it really does come down to funding and the financial sustainability. And that will then inform what the financial sustainability looks like on the hospice model as well. I don't know if that helped provide any other, I guess.
Yeah, I think, Melissa, did you want to say something before I go on what Jessica said?
No, go ahead and continue with Jessica.
Yeah, so exactly what you said is like what I'm thinking about, right? So there's nothing cut and dry. So it's like you almost want to have like a state advisory committee that these people can go to and kind of figure things out when they can't figure it out on their own. But I mean, that everything that you said just makes 100% sense. Like, and when we say, the only thing I keep going back to is when we say and I'm sorry, I have a lozenge in my mouth. When we say the Katie Beckett and then the concurrent care, who applies for Katie Beckett? Like, what makes someone eligible for Katie Beckett, and what is it that they're getting? That's where I'm kind of stuck. So if anybody knows that, I'd love to know more. No takers?
I could do a little bit, at least from what I've seen from my practice, which is on the legal side. But so Katie Beckett, it started a while ago. It was a national program, and it was meant to address this issue of families who do not have financial resources that would make them ineligible for Medicaid, but have a child with really complex health needs that would generally be taken care of in an institutional setting, costing tons of money, but a child who could actually be taken care of at home and integrated into the family. So what it offers, and that's one of the major points of the waiver, is that it allows families who would not normally qualify for Medicaid to get Medicaid for these extraordinarily high expenditures that are expected to continue for a long period of time because the child has complex health needs that are chronic. So what at least I've seen, and what we've kind of seen a little bit in our research, and some of my other colleagues again that we're seeing with folks they've worked with, is that it's a very personalized program that it's very similar to the kind of the palliative goal of comfort care and making sure that the child is well taken care of in the home, but you also have the component of it. It's also, there's coverage for whatever the child needs to stay alive and stay as healthy as possible. So I think that's why it seems like there's a lot of overlap with concurrent care, but you do get children in the Katie Beckett bucket who, once they have those interventions, even if they have very serious healthcare needs, if those healthcare needs are well managed, we're not necessarily looking at a life-limiting illness per se, just they're very medically fragile. And so, as we've been discussed, so then you do get that kind of step potentially over, or the transition over to hospice and concurrent care if it looks like the disease has progressed, or it looks like that it's no longer well controlled, as Jessica was saying. I hope that aligns with other people's experiences on the medical legal side.
Well, to speak to your point, and please correct me if I'm wrong, but I think a lot of the development of that waiver and similar waivers was also prior to us seeing a wider or maybe a broader net being cast through other insurance providers for concurrent care. So when concurrent care was rolled out, of course, that really was Medicaid, right? It took us a long time to get TRICARE on board. And then from there, we're now starting to see that buy-in of insurance, like commercial insurances, and now we're seeing more managed care plans, as you all know. And so I think we're going to continue to see that happen, where there's just a broader range of coverage. And a lot of those families that were ineligible for Medicaid, the only way they could have access to something like concurrent care was through another waiver to be with now. But now, since we have, like, Blue Cross is so incredibly concurrent care friendly, that is an example of a payer that maybe would not have provided that when it was first rolled out, but is now willing to say we'll cover 80% of your hospice coverage, and we're happy to maintain that open door access for any of your other therapies as well.
Okay, now I get it, and I want to go to you, Melissa, but I also want to tell you that I think another pillar that we have to have is that bucket of payers, right? Private payers, what we're seeing with Medicaid and TRICARE, and that has to be one whole bucket that we kind of attack. And there was something else, Jess, you said, oh God, that I wanted to throw in there. Palliative care being sustainable, right? I mean, we have an adult palliative care program here that we do in the assisted livings that we get $24 a visit for. That is a full-time APRN that is seeing those patients, that is helping manage those patients, that's getting $24 a visit. So palliative care, when we're looking at it from our lens in this task force, is something that we need to be able to say, look, we're happy to put them on palliative care, right? And we're happy to follow them, but we can't do it for $24 a visit. I mean, it's not sustainable. So with that, Melissa, I know you've been waiting.
No, I think just my comments in it, I think this ties into a lot of what everybody's saying is, I think we need to keep in mind that we're coming up with a new design. right, for a program. And we need to take into consideration all these different elements, like the payer sources, the regulations, all these things will play a role in terms of how we design this. But we shouldn't allow ourselves to be, and I'm using this word loosely, distracted by the rabbit holes, by the details, but in fact, come up with, maybe some straw models, some examples of, a child with X condition, and then go down, what are the payer sources? What type of resources would they have available? What type of support will they need? And kind of have a design model that takes a bunch of different considerations, some examples, because you can, anytime you look at a situation, a lot of, for example, Katie Beckett, it probably came up at a time when we didn't have a big fix. So Katie Beckett filled a hole. It plugged a hole for something that was much needed in the communities. But now we're talking about it. It's an element of what we want to have as part of our overall program, but it isn't the solution per se. It's one of the ways we have to consider what we're going to do and how we're going to do it. So I think if we think kind of very top level, what should be this design, and then figure out how to make it work from there. You kind of have the end in mind when you're designing something.
Yes. Thank you for that, because that's, but I love how sometimes you just bring the thing to, Melissa and I meet like after these meetings, and she sits and she shows me like slides of what we spoke about, and I'm like, yeah, okay, you like brought it all together. Like that was
in order to get these transcripts done, I have to read everything and go through the entire hour or so that we've talked. So
right.
I'm a little more rehearsed, Tony, and I think so.
Yeah, no, I think and yes, I agree. And I think that, so what I'm hearing, and do we all agree that if we have, different examples that we could one other thing that I wanted to say, I'm sorry, when I think about pillars, and we've discussed this already, but I don't want to lose track of it at some point, is cost versus cost savings, right? So the cost savings that we could see with increased, palliative or pediatric hospice, the savings on the hospital sides, and the less readmissions and emergency room visits, and things like that. So I want to just keep that in mind too. And yes, so I think that's a good point that just went right out of my head that you said. So hold on. See, I get too excited and then I lose going down the rabbit holes, and then also talking about examples of, so kind of making it's not a one size fits all, right? And these are some of the things we see in a pediatric patient that they're coming for hospice or Katie Beckett or whatever, and here is their process through the system. Is that what we're kind of talking about?
I think that's one way to explain it. I don't know if everybody's on board with how we do that, but I think that's one way to show, what the need is, and how we address each and every patient's situation.
So if I can come in here real quick, based on information I sent to the group sometime in September, I guess we were asked to look into how many children were on the Katie Beckett program, and whether or not they were terminally or critically ill. Now, from what I got back for those questions, it stated that there was no data indicating whether the children on the program were terminally or critically ill. However, it says, and I'm looking at my notes here that I sent to the group, but it says that the children on the waiver are terminally ill, but are not terminally ill, but most aligned with being critically ill. And then what we drew from the conclusion that even though there was a wait list for that program, the children on the Katie Beckett waiver will also benefit from palliative care services. So I know that question has already been answered, that the children on the waiver can benefit from palliative care services. However, I know the question now being raised is whether or not concurrent care is also, I mean, how that differs from Katie Beckett. So that's the question I have, and I will research that and send it back to the group. I don't know if that helps.
Absolutely. I think, yes, absolutely. And there was one, because I was just trying to go through the emails that you did send, and one was on the DRG. And I'm just reading through that again, which is, you know, hospital bills, Medicaid program services, the claims are assigned to a DRG group. Okay. Which is, you know, that's very helpful. This ensures hospitals are fairly compensated for the service provided the department. All right, and I'm going to send that back out to everybody too. The payment methodology that can be found on the website. So yeah, as we have like 7 more minutes to go here, but is there anybody who think we have a couple of, you know, we'll see what Melissa comes up with our notes and kind of what our next steps are. But for me, I hear we maybe do a separate meeting with Barbara about regulations. Eileen, I'd love to touch base with you about the whole, you know, the nursing and everything. But then what came out of this meeting and the pillars that we're looking at, and really going forward. And you wonder if at some point, and this may not be appropriate, I don't know, but do we pull in payers? Like, do we meet with payers and understand what it is so that we can discuss it? Yes? Okay, perfect.
And
So,
Tony, Ann, could
Tony,
I, oh, sorry, Regina, just want to make one quick point that when we start to look at cost savings, I know you had mentioned that we look at cost savings to providers, healthcare facilities, but I think we also want to really underscore, and again, acknowledging notably a large proportion of these children are Husky benefits. We want to be able to identify the cost savings to the state and to the potential cost savings to the Husky program. Sorry, Regina, thank you for letting me do that.
no problem. I just wanted clarification. So when you say we're meeting with the payers, who are we looking at, Tony Ann? So I will know if there's any...
like the private payers that are, you know, in most of the areas of Connecticut, like, you know, that either do or don't provide a hospice benefit. We had a newborn on with, I think it was either trisomy 23 or 18, I can't remember what, and the father, she was covered under, and I can't remember what the insurance was, and they were not going to cut. They didn't have a hospice benefit. So that's what I mean by like the private payers, and understand, you know, where they're coming from a concurrent care or hospice perspective.
Okay. And do you still want me to pursue? I know, Barbara, you had thrown out a question as to how we educate Husky providers on concurrent care. Do you guys want me to still pursue that?
That would be
question?
amazing.
Okay.
Yeah.
Okay. All right. Thank you.
Thank you. Okay, we missing Jess, did you want to say something?
I wanted just to say that I really appreciate the pillar approach, and that I think it makes sense to help break up some of those bigger topics into those areas. And I definitely think, and I believe it was one of the pillars you mentioned, but I think a big part of most of this discussion really comes around the idea of hospice eligibility and what defines hospice eligibility for a pediatric patient. And I think there are certainly ways that we can focus that, but I know that it's also one of those rabbit holes that we were talking about, that we go down very easily. But I do think that there's certainly opportunities there to define language in an accessible way that's also going to be flexible for the unique needs that come up in pediatric patients.
100% in agreement. And I have to say, well, this is, and like, you know, these conversations, and even the rabbit hole conversations, I like appreciate this call so much, because it's, and the more I'm learning, like you think you kind of know, okay, I think I know pediatric hospice, but like I'm learning something new every day. And I think we're in a really good place and going to have an ability to really move the needle forward here. Elle, I see you have your hand up.
It's just super quick on Katie Beckett and concurrent care. I will double check this because I haven't seen, I'm not involved in the case management for any of the children who are attached to my clients, but generally Katie Beckett is a way for people to get Medicaid coverage who wouldn't otherwise qualify. So my understanding is that if you are under Katie Beckett, you have access, that child would have access to all the regular Medicaid benefits, including the hospice benefit. So that might be the way that Katie Beckett and Hospice connect, just
Okay. Perfect.
So we've talked about having some speakers on our calls, our action team calls, and also advisory calls. Is it possible to get is Katie Beckett, those folks, the right people to have for our small team? Or I'm just thinking ahead. Do we need to pick their brains or have them do a briefing for us on our next call?
I think maybe it would be good for our team. And Barb, I don't know, did Dr. Moss talk to you about you next time talking to the advisory council?
She hasn't mentioned it yet, but it's about MOLST, right?
Yes.
I'm always happy to talk about MOLST.
Okay, so you're probably,
if she does it 5 minutes ahead of time, I can tee it up.
Perfect. Okay.
Yep, no pressure there.
Yeah, so I do think, so the Katie, that would be good because we want to understand it as much as possible, right? So I think it would be good for this group to hear, more on that. And I'm trying to toss in my head, Barb, like I guess the savings to the state per se. Where could we, could we ever get to the point where it's somewhat like, I want to think about that more, because that would be like, how do we save the state money through this?
I think, and I'm not an expert on this, but this is my high level thought. All of these pillars are interconnected. And if we're providing children good concurrent care during their hospice care, the overarching goal is you're going to mitigate risk for future hospitalizations.
Right.
I think, but again, I'm not the expert.
Mm-hmm. I think we were looking at hospital data to look at length of stay and admission, because we also know that even if they are admitted, their length of stay tends to be shorter since they have a resource in the community that's already in place for that continuity, for med management, for education. So they're not needing as much support at an inpatient level. But I think even if we look at things like vent management and knowing that a child may be on a vent, but because they're with a hospice program and they're able to have more in-depth conversations about goals of care and advanced care directives, it may limit that family may choose to limit intervention or to discontinue intervention, as well, for quality and just understanding what that looks like for their child. And in turn, not to be crass, but that does also save money on that state-based policy as well, since they're not paying the daily rate for the vent.
Absolutely. And you know what, that was my bad. I was separating even the Medicaid from how do we save the state money. So that was it all comes together. So yes.
I think it would be because probably everybody, most people in this team have actual dollars and cents associated with care support, whether it's the technical equipment or the hospitalization, things like that, to show if on concurrent care we do this, or if no concurrent care, then hospitalization. So I think it's a pretty dramatic comparison of, if we support them properly, the cost is much lower. If we don't, then the cost dramatically increases because of more extreme interventions that are required.
So quick question, Melissa, are you going to follow up on getting somebody from Katie Beckett to join us on the next meeting, or how are you?
I just threw that out there. I wasn't even sure if that was something we were interested in.
Okay.
And by the way, Regina, I don't know anybody at Cater Beckett,
Okay,
so
okay,
somebody
so
else
I
would
can
have
look
to,
into that too.
yeah.
Okay,
yeah,
okay.
if that's what we wanted.
okay.
Perfect. Okay. Thank you all so much. I know I kept you a minute over, but this is just great stuff. I will get in touch with everybody that we're going to meet with separately, and then I think it would be nice to put together a nice one, especially for the regulations. And then Eileen, I'll also be reaching out to you. Okay. Thank you all so